Hey, good afternoon. I'm Dr. Barton. I'm the ENT doc here at JRMC. I've been asked to provide you with a little instruction today about ear tube surgery, and so we'll take a few minutes and just kind of run through the ins and outs of the surgery and talk about who needs it. And we'll actually do a little bit of anatomy review also. Kitty, I lost the video on this. Is there a way to bring that back up?
Sure.
Oh, there it is.
You are.
Okay, good. So, first thought is, if I had to summarize the whole procedure of ear tubes, I would tell you it is due to eustachian tube dysfunction. And then, of course, that brings up the question, well, what is a eustachian tube? And if it's dysfunctioning, what does it mean when it properly functions? So I've got a couple of little anatomy charts here that we'll look at and talk about what the eustachian tube is and where it's located and how it's supposed to function properly. And then once we've kind of laid that foundation, then we can talk a little bit more about the ear tubes. So here's a little anatomy chart. Let's see if I got that on the camera right. Here we go. So if you take the head, turn it to the side, and if you kind of looked through half of the head, you'd see the nasal cavity here. This is the inside of your nose. And if you went all the way into the back of your nose and touched the back wall, this is kind of back of the nose, top of the throat area, you'd find these little slit-like openings that there's one on each side, left and right. And these little slit-like openings lead into a little tube, and that's the eustachian tube. And that tube leads up to the space on the inside of the eardrum. Now I'm going to switch to a different chart here that's got a blow-up version of this. Okay, let me get centered here. All right, so here's our smaller view of that head, that tiny little slit there in the back, and then here's a larger view of that eustachian tube as it leads to the ear, to this little space. It's called the middle ear space. That's the space underneath the eardrum. So if you were an ant and you could climb inside the nose and go up that tiny little slit and then climb up that tube, you'd be looking out of the eardrum. And if you took a little light and you shined it from the outside, you'd be looking at the outer surface of that, so you'd be one on each side. The eustachian tube is designed to equalize pressure on the outside part and the inside parts of the eardrum. So you probably experience this if you have gone up and down an airplane or driven up and down mountain roads, scuba dive, anything like that where air pressure changes. When the outer pressure changes, let's say it goes up, it's going to want to push the eardrum in. And if we don't have some way to equalize that pressure on the inside here, then the eardrum will just continue to get pushed in, and that hurts. It can also cause fluid to fill inside that space there. So the proper function of the eustachian tube is to allow air to go through the back of the nose, up this little tube, and equalize that pressure. So now the eardrum is not pushed in, it's still kind of in a neutral position. And then the opposite thing happens if the air pressure drops outside. The air pressure wants to push the eardrum out. And so in that case, you got to let some air out of this little area there to equalize the pressure. So when we use the term eustachian tube dysfunction, what we're talking about is a eustachian tube that does not allow air pressure to move in and out. And so as a result, you'll get an eardrum that in most cases gets pushed in, because the most common problem with eustachian tubes is they won't let air come up. It's a little easier for it to go out than it is to come up. And you probably experienced that in an airplane. When you take off, the outside air pressure drops, and that would tend to make the eardrum want to push out. The higher air pressure here inside this space needs to then leak out to equalize, and that's pretty easy, even if you have a cold or flu. On the other hand, if you got that same cold or flu and you've just flown and it's time to come down, during descent, the outside air pressure increases, and now it starts to push the eardrum in. And that's when most people have trouble, is during that descent phase, getting ready to land. So you'll see people moving their jaw, chewing gum, yawning, or holding their nose and blowing. And what they're doing is increasing pressure inside the nose and then pushing that air up into this space so that it equalizes the air pressure there, so their eardrum doesn't continue to get pushed in as the plane descends. So eustachian tube dysfunction is pretty common in little children, probably up to about the age of 3 years old or so. And then after about age 3 or 4, most children will grow out of it. But up until that time, their eustachian tubes just don't work very well, and it's just kind of an anatomical thing about the way their size and shape is. That gets a little bit better as their head and neck starts to grow and the angles start to change. But during those first few years, it's pretty common to have eustachian tube dysfunction where you can't equalize pressure. Once again, that usually means a negative pressure or a vacuum on the undersurface of that eardrum, and then that space can fill with fluid. When it fills with fluid, it can give you hearing loss. You probably experienced that if you ever had a cold or a flu and you sort of feel that muffled sensation in your ear. Children can have that too. Of course, it's hard for them to express that to us. But if they get that fluid behind there, that can cause some hearing loss. And during their developmental years, we worry about hearing loss causing speech delays. So one of the more serious issues that we deal with in relation to eustachian tube dysfunction is hearing loss and speech delay. And if you don't address that early on and the children get behind in their speech development, it can be hard to catch up later on. So that's one of the more important reasons to do ear tube surgery. Now, the more common reason to do ear tube surgery is sometimes that fluid in there will get infected. And so that's where you see these recurrent ear infections in little children. In those cases, putting an ear tube in here acts to bypass the eustachian tube. So we've got eustachian tube dysfunction. We can't really make this tube work any better, so our best option is to bypass it, and that's what an ear tube does. In order to put an ear tube in, we'll cut a little hole in the eardrum, and now let's see if I got my picture here. This is a picture of an eardrum with a little tiny knife under a microscope. And then here's an example of a little ear tube going through the eardrum. And you notice there's a little hole in the center of that tube. I'll show you some of these here in just a minute. And that hole allows air pressure to move in and out of there. So it basically acts like an artificial eustachian tube. If I can't move the air back and forth here, I'll simply move it across the eardrum, equalize that pressure, make sure I don't have a buildup of fluid, and allow the eardrum to move more normally so we can make sure to maintain good hearing and hopefully good speech. All right, I think that's probably all the basics for eustachian tube dysfunction and sort of the beginnings of a discussion on ear tubes. Now, I've got some little examples here, and I'm not sure how well this is going to show up.
Want me to hold that up?
Let's see. What I'll do is I'll kind of grab our penny, and let's see, I'll sort of show that there. And then, let's see, let me get... This is an example of an ear tube. This one is actually made of metal. You can see how small it is. It's got a tiny little hole in the middle of it. I'll show you another one. This one is made of a soft silastic material. Once again, you can kind of see the size of that thing compared to a penny. And a penny is roughly the size of your eardrum. Notice that little hole in the middle of it there. I also just made a little pretend eardrum model. I just took a little 3x5 card and put some tape across here. You could pretend that those little holes in the middle are where the eardrum is. And this is kind of how those ear tubes would fit through there. This is an ear tube that's got a little bit longer shaft on it. And then on the inside of the eardrum, you see these tiny little flanges there. This is a different style of ear tube. It just has flat flanges on both sides. And it's those flanges that hold the ear tubes in place. They typically will stay in the eardrum for about a year. Anywhere between about 6 months to 18 months is kind of the average range that the ear tubes will stay in there. And then normally what will happen is as the skin and the tissues of the eardrum grow, they'll push the eardrum, the ear tube out, and most of the time they'll fall out spontaneously somewhere around that 1 year range. Some questions that often come up are, when do you meet the indications, or what are the proper reasons to do ear tubes? So we wouldn't take somebody to the operating room just based on one ear infection. On the other hand, we don't want to wait until you've got 100 ear infections before we start to consider that. So we've kind of looked at some numbers and figured that if you get 3 ear infections within about a 6-month period, or if you get 4 ear infections within about a 1 year period, that's enough to justify doing ear tube surgery. Doesn't mean you have to do it, because there are other options. Antibiotics are certainly fine to use. You just have to weigh the pros and cons between repeated uses of antibiotics and the risks and benefits of going under anesthesia and having ear tube surgery. I tell parents that it's probably okay for them to choose either one of those, because they're both going to end up with about the same outcome as you follow those children down the road. You know, by the time they're 6 or 7 or 8 years old, those that used antibiotics and those that used ear tube surgery will probably end up about the same. That's not true, however, for the children who have eustachian tube dysfunction that causes hearing loss and speech delay. In those cases, we're actually a little bit more aggressive with our ear tube surgery, because we want to restore that normal hearing and allow those children to develop their speech properly. If we wait until they're 6 to 8 years old, they can get far enough behind in speech that it can be hard to catch up. So those are sort of the numbers that we think about: 3 and 6 months, 4 and a year. There are some other less common indications when we might do ear tubes, but far and away the ear infections and the fluid behind the ear causing hearing loss are the most common ones. A typical ear tube surgery is a same-day surgery. You come in the morning, you go to the operating room, and you're in the operating room for about 20 to 30 minutes. Most children don't need a breathing tube or even an IV. We just give them some anesthesia with a gas mask. They breathe that in, they fall asleep. We bring our microscope in, and then we've got our knife and tiny little instruments like this that go inside the ear so that we can put that ear tube in. If there's fluid behind the eardrum, then we'll suction that fluid out. We'll put some eardrops in, do the same thing on the other side, and in most cases about 5 or 10 minutes later the surgery's done. Then it takes about 5 or 10 minutes to go to sleep and to wake up. So, probably overall they're in the operating room for about a half hour. They go from the recovery room back over to the same-day surgery area, and they're usually home before lunchtime. So if you're thinking about what would my typical day look like, it'd be coming in the morning and probably being home by lunchtime. Normally, you'll recover within that same day of surgery too. So if children were in school, daycare, preschool, any of those things, they can normally go back the next day. The anesthesia sort of wears off by the end of that afternoon, and they're kind of back to feeling normal again. They might go home with some eardrops, but normally those are the only medicines that you need after the surgery. And you might use those eardrops for 3 to 7 days, depending on what we find when we're in there doing the operation. Normally you don't need any other antibiotics, and normally you don't need any pain medicines either. So pretty easy recovery. Let's think here. A lot of questions that will come up are regarding the care for the ear tubes after surgery. So I put ear tubes in, I see you back a month later. We check the ear tubes to make sure that they look good. Remember I mentioned that they'll fall out normally at about the 1 year point, but every once in a while the body will kind of reject that ear tube and it'll spit it out a little earlier than we expected. So I'll see you back at the 1 month point to check that ear tube, make sure it hasn't gotten extruded or rejected, and then afterwards we see you every 6 months. If we needed to do a hearing test, then we would do that hearing test about 1 or 2 months after surgery to compare it with what we saw beforehand, just to make sure things are getting better. Parents will ask about earplugs and being able to go swimming. And this has been a big change since, my generation were kids. Back in the old days, we used to tell folks that you can't go swimming if you've got ear tubes. And then we realized that was probably a little excessive. So then we kind of moved to saying, well, as long as you put earplugs in there and don't let the water get in, then you're probably safe. And now we sort of realize that that probably isn't even necessary all the time. So the way I describe it is if you're going to be splashing around on the surface, there's very little risk of getting water inside there to the degree that you would get an ear infection. It's never wrong to use earplugs, but in most cases you don't have to. If you're in chlorinated pool water, in theory that's pretty safe, so that would be very unlikely to cause an ear infection. If you're in dirty water, so this would be like a child who likes to put their head under when they take a bath, or if they're going to lakes, rivers, oceans, creeks, that kind of stuff. If they like to go under the water, sometimes that water can get down inside there and it could go through the ear tube and cause a little ear infection on the inside. If that happens, it's pretty easily treated with some ear drops for a few days. So even if you do get an ear infection, it's not the end of the world. And then sometimes after that, parents will decide that they'd rather be safe than sorry, and they'll just use the earplugs. And there's certainly nothing wrong with the use of earplugs. But I just tell parents I don't want to stifle their children's activity, especially being able to go swimming, because they can still do that in most cases, even with ear tubes in place. Let's think. Can we think of any other common questions?
Is there any genetic predisposition to kiddos that need this kind of care?
It's so common that we don't track it in most cases. So if you have some conditions like maybe Down syndrome, or if you had a cleft lip or palate, or if you had some other craniofacial deformities, things that affect the way the skull and the face bones grow, sometimes that can affect the eustachian tube, and those children are more likely to need ear tubes when they're young, and even as they grow older. A lot of times they don't outgrow the eustachian tube problem, and they have to keep replacing them during their lifetime to make sure their eustachian tubes are bypassed, because their eustachian tubes may never function normally. Remember, in most children they'll outgrow it by around age 3 or 4, but if you've got some other issues that affect the growth and development of the facial bones and the skull bones and those bones that surround the back of the nose and the ear, then that might make you a little bit more predisposed. I do get a lot of questions. Mom and dad will say, well, Uncle Johnny needed ear tubes, or Mom or Dad needed ear tubes. Does that mean that that little Susie is going to need ear tubes? And I tell them, not necessarily. Certainly, genetics are genetics, and you've got the DNA that your parents had, so you're probably predisposed to get whatever they've got, but it's such a common condition that it's just not something that we tend to track. So I just describe it to parents as a very common thing and not necessarily related to family history.
Okay, that's what we have.
That was it? Okay. Let's see. Let me look at my little cheat sheet here and see if we have any other ones that we missed. I think that was about it for our sheet here too. So.
Okay, awesome. We'll just say thank you and.
All right. Hope you all have a good day, a good weekend, and look forward to seeing you if you end up coming to my clinic. Bye-bye.
Done.
All right.
Perfect. Thank you very much.
Sure.
Did you think it went okay? Anything for next time to do different?
Let's see. If I want to do a little show and tell, I might try to figure out a better way to do that. I showed it in front of the camera, and as I was trying to look, I just thought, I don't know how well that's... I think my wife watched it, so I can ask her.
Just request requested to join. I just
Oh,
saw
okay.
that. But oh look, Dr. Barton is the best. Yay. Madison Barton.
Oh, that's my job. Oh, now this could be interesting. Did you see? So Linda told the kids that I was going to be
Yeah.
on this, and
Oh,
so
good.
they all got together and they're like, okay, let's call in or do something, and we're going to use funny names. So you can imagine the stuff they were. And Linda was like,
Excellent.
"Don't you guys dare mess with Dad!" Right? You know. So I was kind of curious if somebody was going to write in with some, those silly names.
Just that Dr. Barton is the best.
Oh, okay.
And we approved. I'm guessing that was your wife.
Hmm.
Okay. Well, we might get questions afterwards, and
Okay.
I'll look through what you said and see if I can answer it to the best of my knowledge. And if I can't, I'll shoot it to you.
Okay.
And when it gets to like the really personal ones, I just say, sounds like the best course of action is to
That's
schedule
good.
them.
Come see me in clinic.
Yeah.
Yeah, that's always a tough one to try and answer specific things.